Good morning, America, and welcome to this morning's huddle brought to you by Going on Offense. My name is Darrell Moon, and I'll be your host today because we're having some trouble with the video portion. We're going to just do this audio today, so you won't be able to see us, but we'll still have the conversation. Hopefully, you'll enjoy it just as well. Thank you for being with us. We hope you enjoy the conversation. I have a wonderful guest with me today, talking about employers struggling with the challenge of testing and bringing employees back into the work site. We're holding these huddles every Monday, Wednesday, and Friday in an effort to be supportive to those who are struggling in light of the pandemic, to brainstorm strategies to help, to promote resources to help those who may be struggling emotionally, and to engage collaboration. Now to introduce today's guest. It's my pleasure to introduce to you Dr. Timothy Grahm, MD, in endocrinology, diabetes, and metabolism. I'm going to give Dr. Grahm a couple of minutes, 4 or 5, to just introduce himself and to share a comment or two about today's topic. But before I do, I want to invite you, our attendees, to join the conversation. Please feel free to send in questions through your control box or simply raise your hand and I can turn your mic on and you can join the conversation and participate through audio. Dr. Grahm, would you like to introduce yourself?
Yes, thank you, Darrell, very much. And I apologize to everyone that video doesn't seem to be working from my medical office here. Having said that, I think we can definitely provide some good discussion and thoughts for you as you send in questions. So as Darrell said, I am a medical doctor. I've been practicing for about 25 to 30 years. I'm also a cell biologist and scientist, and currently the chief scientific officer for Progenitor Molecular Diagnostics. My company is a long-term molecular diagnostics specialist run company. Our CEO was responsible for some of the original screening approaches for human papillomavirus, which is the key cause of cervical cancer. So we've been doing this for a long time. When the SARS-CoV-2 virus and COVID-19 illness emerged, we quickly retooled a lot of our capabilities to start testing in large sample numbers for COVID-19. We're doing what's called PCR testing, which is the method that is FDA approved for detection of actual active infection with the virus. We believe that it's not enough to just do testing. We feel like in order to really be helpful with companies coming back with business and bringing their workforce back to face-to-face interactions, it's going to be necessary to support human resources and employee health departments with coming up with a testing strategy that makes sense from a scientific standpoint and a medical standpoint, as well as help them craft policy and procedures for responding to positive tests. So I'm just going to leave it at that, but that's kind of the gist of what we're doing. We're not just testing, we're trying to also help companies come up with a rational strategy for managing COVID-19.
So Dr. Grahm, I want to just bring up to start off the conversation a real need that I've uncovered just in the last week. So my son, who works at a manufacturing plant that's considered essential and have continued to operate because of some of the work they do for the government, in their policies, if an employee is exposed to someone with COVID or was exposed to someone who later became positive for COVID, their policy is that that person needs to basically stay on quarantine. They don't have any symptoms, basically just stay on quarantine for 2 weeks. And in my son's situation, it's like, wait a second, that means he's got to take PTO for 2 weeks and can't go into work, can't do his job. And I would think for many employers, this, the fact that you have to have symptoms in order to be tested creates a huge gap in the system where employees, they can't afford to just have their employees be on quarantine for 2 weeks. And employers are going to need strategies to get their employees tested, to bring them back to work and to get them working and to not just simply shut down for 2 weeks. What are your thoughts about that?
Well, I think that's a great example. I would say it's even more problematic as some companies, in an effort to even support their employees more strongly, have even committed to paying for hotel housing for infected employees so that they don't have to go back to their families, especially if they contracted COVID in the workplace. I don't think most companies are doing that, but I'm just saying that to underline and underscore how costly even a single case can be for a company, depending on how they intend to support their worker. Not to mention the loss of the position that the worker provides to the company as well. So we feel that constant surveillance of the worker populations is probably the way to go. If you can prevent even one or two cases, it probably pays for itself. Individual testing is very expensive. It's on the order of about $100 per PCR test. And that, you can imagine, racks up really quickly if you've got 200 employees being tested once a week, for instance, for a medium-sized company.
Right.
We and others are trying to pioneer what's called pooled testing, where we can test perhaps up to 50 or 100 employees with a single test. And then if there is no one positive, they can proceed according to normal plan. If one of them is one of the pooled tests comes back positive, then we what's called deconvolute. We break down all the individual samples and look to find who in that group is positive. It's really effective when you're in a situation where there is not a lot of disease present, but you also don't want to miss the few cases that are there. So that's a great strategy that dramatically reduces cost. Right now, there are very few groups doing this, and we're kind of, even ourselves are trying to figure out what the optimal test batch, that optimal pool size is.
So that's fascinating to me. Let's get into that just a little bit. So you take let's say there's 50 employees working at a work site. You take the sample from all 50, you then pull them into one sample, run that one test through, and if that comes back positive, then you begin to break it down?
Exactly, yeah. And so you can see that, the cost efficiency there is amazing. 50 tests at $100 is, going to be, what's that work out to? It's $5,000.
Yeah, $5,000.
And as opposed to one test at $100, basically. It's partly possible because of the sensitivity of the technique of PCR that's being used. It can pick up as few as one or two virus copy numbers in a pooled sample.
Wow. So would the process of taking the sample be the same? Is it the Q-tip up the nose, kind of a sampling process?
Yeah, it is, unfortunately. There are a couple, there are now three sort of approved ways to do this. There's the Nasopharyngeal Swab, which is a kind of a little nylon thing on a end of a plastic pole, so to speak, that you shove into the back of someone's nose. It's very unpleasant, I got to tell you. I've had it done, and I've had to do it for some patients. There's also now a Q-tip into the nostril. You go up high, just as if you were, I hate to say it, but just as if you were picking your nose. You can go up with the Q-tip quite high, swoop it around in each nostril, and then send that material in. Right now, the FDA approves one or the other approach depending on what test is being paired with it. It's very complex with the FDA. The third way is spit collection, and there are only a few that are approved for spit collection, and they really haven't been tested as extensively as we'd like them to be, though you can imagine that would definitely be the easiest way to collect samples from employees.
Well, so let's talk about whether those are self-administered or administered by a third party. So in the case of the Q-tip and the spit, could the employees literally just receive a kit, provide the sample and send it in, or would they all need to go to some kind of a testing location?
So at the moment, under the emergency use authorizations that the FDA has provided, all of these have to be performed under medical supervision. So you can hand the swab to a patient and let them do it itself, but do it themselves. But you need to be someone with some sort of medical background, whether it's a medical assistant, or it doesn't even have to be someone with high credentials, has to be there present, making sure it's done right. I believe the same is true for the spit collection, which seems kind of crazy to me because it's spit. So I think that will probably change, and I think that there will be the possibility eventually of having a kit at home that is just mailed in, FedExed in regularly on a weekly basis.
Would the veracity of the sample be a part of the problem as to why the third party has to be there, so that
Yeah.
it's not the employee saying to their spouse, "Here, spit in this collector, and I'm going to send it in"?
Yeah. Actually, I think that's one of the factors. In fact, the FDA has been very reluctant to approve any home testing for COVID at this time. The antibody tests are being deployed ahead of approval to direct to consumer. They actually there was an injunction to pull them off the market when the FDA became aware of that. There is definitely a problem with think about it. Employees don't want to test positive because it's going to mean they lose paycheck.
Yeah. Well, or employers are going to have a policy where they allow those people to go on quarantine and still get paid. I mean, obviously that's more expensive, but in today's environment, I think some employers are probably open to doing that.
Yeah, that's definitely true. I mean, you don't want, there's got to be some retention policies out there, or else you're going to lose a chunk of your workforce permanently.
So I want to pursue this just a little bit further. So I love what you just said about the pool testing. It would be incredibly expensive for an employer to regularly test all of their employees, but it would not be at all inconceivable to have everybody as they came into work provide a sample and run that sample for the day. And you could even do that almost every day with all of your employees, just to make sure you've got a clean work environment where everyone can feel comfortable and basically work as normal. Or probably want to have some prevention, but in the event, as you keep doing that, someone were to show positive, then it's like, okay, everything changes. Now we do a test on everybody, and now we find who the problem is, and then we send, and you only have to be shut down maybe for a day while you're waiting for that test to come back, and then everybody else comes back to work. I think it's an incredible strategy.
Yeah, I would. Oops, let me turn this off here. Sorry. I would actually go so far as to say you could even be more efficient with it. So, for instance, if a company wanted to identify critical work groups that really they want to have working face to face on a regular basis, you could break down your organization into, say, let's say you've got 400 employees. You could break it down into 8 groups of 50 employees, and you would basically want to keep those groups somewhat sequestered from each other, right, so that when you do pooled testing, you do it on a work group by work group basis.
Right.
And so then if you do have a positive, instead of having to go back and test 400 employees, which is suddenly very expensive, you can just go back and test the 50 work group in the work group who are already sequestered from the other work groups. That would be kind of one of the ideal approaches to strategize a cost-effective approach.
Right. I'd like to invite our attendees to send in questions, or just allow me to turn on your mic by raising your hand, because this is a fascinating discussion. Let's talk a little bit about the various issues that employers have to consider, because I think one of the things that this whole pandemic has brought light is that in the past, employers were employers, and very few employers were in the medical space. Nobody had a medical director, nobody had, you don't need that. But today, that's all changed, and the need to have support from a medical director to just develop policies, to have guidance in terms of how you deal with this health issue that now exists in almost every, or the risk for it now exists in almost every work environment. Give me your thoughts on that.
Well, imagine being an HR director and suddenly having this dropped on your desk. I mean, I don't think anyone who went into employee relations in HR was ever planning to, suddenly have to, implement a huge diagnostic testing strategy, and then, gosh forbid that you suddenly end up with a handful of positive patients. What do you do then? So to me, the ideal sort of services would be, someone who can come in, help craft policy with you that makes sense from a medical as well as a medical legal standpoint, implement that policy through the testing, have a plan for how to deal with positive individuals, both medical and legal in nature. And then, frankly, there's probably, if you're testing, there's probably some responsibility to do at least some minimal contact tracing. And, if you could put all that together in one package, it sure would be a lot easier than, asking, your HR director to try to figure this out.
Well, and I would think that would be a huge stress reducer just for the company. The companies are busy doing their business. The last thing they need to be spending all their time worrying about is just the safe environment that their employees work in. So having a contracted medical director that can help you develop policies and can be there to respond if an issue came up would be huge. And I'd love to, again, hear from those who are attending. If you've got thoughts along those lines, whether you agree or disagree, please share those. Now, one attendee has asked a question. We may have already answered this, but if someone tests positive in their pooled group, then all employees need to be tested again. And yes, that's basically the case, right? Or do you actually have the samples that you can then start to run those tests on each sample?
That's a great logistical question. And the good news is we actually keep the samples. So when we do pooling, we keep all the original samples. We only need, well, first off, when we do pooling, we just need a small portion of each sample. The rest of those can go in the freezer. And as soon as we find a positive, we can break those back out of the freezer, thaw them, and start testing for the individual in that group, in that pooled group who may have been the positive.
Very nice. Very nice. That's cool. And you may or may not know this answer, but right now, if a person is exposed to someone with COVID-19 and they don't have symptoms, and maybe it varies from state to state, but here in Utah, where we're running this broadcast, are there places that a person who has no symptoms but feels like they've been exposed can go get to be tested, or do you have to have symptoms to get tested?
When the pandemic originally sort of evolved, it was required by most testing facilities, which in some cases were state-sponsored, in other cases were hospital-sponsored, that you have to have symptoms. The problem is we all are aware that so many people are asymptomatic with this, and indeed, there's just been publications that it's often the asymptomatic people who are what are called super spreaders, who can, single person can in one event pass on to 30 to, I think the highest that's been calculated or estimated, one group, they had thought one person passed on to 80 individuals in a closed environment. So there is definite benefit, obviously, in testing people who don't have symptoms. And so, for instance, here in Utah, we now have available drive-up testing for asymptomatic people. Now, they will screen you for symptoms because they like to be able to provide that information to state health and county health agencies, but there's not a requirement for symptoms right now. That probably differs from state to state and location to location, though.
So I know my son tried to get tested. He didn't have symptoms and he was turned away from a testing place. So are there specific places that you have to go to get tested if you don't have symptoms?
Yeah, it's actually a good question. I mean, here, so for instance, at my current medical facility, I'm in a medical corporation when I'm not with Progenitor. Their policy is you should have symptoms, and they actually screen all tests beforehand. In fact, even when I order it on a patient, they force me to click off a bunch of boxes that, they tell me either the patient should be tested or not. However, we also have a program that was developed by a private group, a group of tech people who invested in a lot of testing capability with the goal of helping people get back to work here in Utah. And so they're providing testing without symptoms. It's a program called Test Utah. There's a similar program in Nebraska and a similar program in Iowa called Test Iowa and Test Nebraska that are kind of more available to people who are just worried about exposure.
Well, and I would think, because you said those super spreaders are the ones we need to worry about the most. It's like we need to get anybody that's been exposed tested to see if those people need to stay in quarantine for 2 weeks, because 2 weeks is a long time. If you don't know if you got it, and you got some family members that are on quarantine. It's tough to just sit for 2 weeks and do nothing, where if it's like, I can go get tested, I can see if I'm positive or not, then I go back to my normal life. So
Yeah,
now we've got
yeah,
a
that's
question that
right.
just came in, and that is, what is the false positive rate of the pooled group? And likewise, what is the false negative rate of the pooled test? Do we know?
Yeah, so I mean, that's a great question. That's exactly what we're trying to figure out in our own strategies. Now, what's interesting about that question is the false positive rate, which is kind of related to the positive predictive value, which is I think one of the key questions is, well, actually, the bigger question is the negative predictive value with the pooled testing, because if you say if you say a work group is clean, you better be right on that.
Right.
So that is directly influenced by the prevalence of infections in the community. Now, you can imagine, you've got to combine that calculation with the calculation of the actual sensitivity of the pooled testing, which we're trying to figure out whether it's compatible with 25, 50, or 100. We're doing those experiments right now. That has to be combined with further the number of that you're testing in the pool. So there is this kind of weird sweet spot you got to find where you're testing the right number of people in the pool, you've got the right sensitivity of the test, and you can kind of calculate the negative predictive value. Now, honestly, you got to think about this. It's not going to be 100%. So what you're really kind of buying into with pooled testing is getting kind of some degree of insurance. Now, it's not is necessarily going to be 100% in all cases, but neither, for that matter, is individual testing across, say 50 people. You're going to have, several false negatives. So
That makes sense.
but to answer the question, we don't actually know, and we're trying to mathematically model that right now, believe it or not. And like I said, I don't think we're the only ones working through this problem. This is definitely going to be the future for how we do this.
Well, and let's talk a little bit about the fact that, everybody's kind of said, well, we just need to wait 12 to 18 months and then there'll be a vaccine. Everybody can just get vaccinated and then we don't have to worry about it anymore. But it's not always the case that we can find a vaccine for a virus. Is that correct? I mean, some viruses we'll never find a vaccine for.
Yeah, I mean, it's even a bigger problem with COVID-19 or SARS-CoV-2, the virus. These coronaviruses often become endemic in populations, meaning they simply can't be eradicated, even with efforts at vaccination. And that's partly because, kind of like the flu, they're able to sort of escape some of the strategies that we use for vaccination. There are now about 8 endemic coronaviruses, and unlike the original pandemic coronaviruses, which you guys may remember, SARS, that occurred a few years ago, and then the Middle Eastern one, MERS, MERS. The current COVID-19 actually behaves more like the endemic ones than it does like the pandemic ones, even though it is a pandemic virus right now. The thought right now by most scientists is it will become endemic. It's going to keep coming back. We don't know, and this is perhaps the scariest part, we simply do not know if antibodies confer immunity. And when the current approaches to immunization are to have the person who gets immunized produce antibodies, ideally antibodies that bind to and neutralize the part of the virus that actually can connect with cells to cause the infection. Those are called neutralizing antibodies.
Right.
And we really don't know if neutralizing antibodies are going to be enough to prevent reinfection. There is certainly data already being published out of China and Korea, where the pandemic sort of took off earlier, that many individuals who have positive antibodies in their blood are getting reinfected. So some of those individuals have, neutralizing antibodies that their own immune system made without vaccination, and yet they're getting reinfected. So that's kind of a scary thing about this virus.
Yeah. So talk to me a little bit about some prevention strategies that do or don't make sense. I read an article the other day about nasal rinsing or irrigation that is very common in some of the Asian countries that have not seen a high level of prevalence of this. Is the practice of nasal rinsing something that we should be considering as a way to, if we do get it, make the symptoms less or at least be less contagious?
It's an interesting question. I don't think we've seen much of that in the American medical literature as a sort of a testable method or even sort of reported as case reports. I will tell you this, from a medical standpoint, I would be very worried about doing regular nasal rinsing, because what you're really doing is irritating and stripping down the lining of the nasal pharyngeal passages. And that's the first barrier to any infection, are those passages. And so if you irritate that, you're kind of inviting not only viral infections, but bacterial infections and a lot of others. And certainly rinsing repeatedly would do that, I think. So from a sort of empirical standpoint, I would say probably not a great idea, but maybe there'll be some data out there that says otherwise. So never say never.
Right. Again, I encourage people to send in their own questions. I've got another question. That is, I don't know if I'm pronouncing this correctly, but cytokine storm syndrome. Talk a little bit about the fact that in some cases, patients their own immune system is causing these storms, which is more dangerous than the virus itself.
Yeah, I think you can safely say that the virus is not killing people. It's our own immune systems that are killing people. So there's a couple really fascinating, unusual things about this virus. First off, consider this. The people who are most likely to die of the virus are diabetic patients. That makes no sense for a respiratory virus. So, usually respiratory viruses like influenza, RSV, are way more likely to kill people who have a history of asthma or a history of chronic obstructive pulmonary disease, which is a combination of emphysema and bronchitis. These people get picked off, unfortunately, like very early on in sort of influenza pandemics. This is not happening. It's diabetic patients, which is insane. So we don't.
Which are a lot of your patients.
Oh yeah, that's one of the. Yeah, oh yeah, absolutely. I mean, that's like one of my interesting kind of dual roles here is, counseling patients who are at super high risk, as well as trying to figure out how to test populations. So this is interesting. I just heard this statistic. 1 out of 10 individuals with diabetes who contract COVID-19 die within 7 days. That's yeah. So not only do they die in higher numbers, 10% is huge. I mean, compared to the average is probably more like 0.3 or 0.4% nationally. Not only is that number huge, but they die quickly. So it's very virulent to diabetics. There's a lot of theories about this, and one of the theories is that the virus itself is mostly active in the small blood vessels of the body, including the blood vessels of the lung. In the lung, that causes edema or release of fluid. But in smaller blood vessels, it causes kidney failure, it induces strokes. And we're actually seeing young, healthy people with COVID-19 getting strokes, which is, again, a tip-off that it's not just a lung thing. And we're also, just recently, there's been a lot of data in kids who've had asymptomatic infections, who've clearly been infected, coming down with a vasculitis, which is an inflammation of the blood vessels. So this is probably attacking blood vessels more than it's attacking lung, but lung shows up as sort of the most vulnerable tissue for a lot of people.
And would it be both diabetic type 2 and type 1, or is that statistic specific to one or the other?
Yeah, that's a good question. And believe me, I got to deal with this every day with my patients because I have about a mix of both. I personally think it's going to be type 2 diabetics for a lot of different reasons. Type 2 diabetics are more prone to vascular injury than type 1 diabetics, especially if it's a well-controlled type 1 diabetic. The biggest problem type 1 diabetics have is that they just don't make insulin. As long as we give them the right amount of insulin, they're really not too different health-wise than most people if we control their blood sugar with the right amount of insulin. Type 2 diabetics, by the time they're diagnosed, they've had a condition for at least usually 5 to 10 years called insulin resistance. Insulin resistance, even if you don't have high blood sugar, insulin resistance predisposes you to all sorts of vascular catastrophes. I mean, heart attacks, strokes, kidney failure, even before you develop the high blood sugar that defines diabetes. So I believe that probably what we're going to find out when we break down the data is it's mostly older type 2 diabetics, especially those who already have multiple other medical problems who are at highest risk. having said that, I'm cautioning all my diabetics, including my young, healthy type 1s, to be super careful.
Yeah. So is insulin resistance the same thing as prediabetes?
Yes and no. People with insulin resistance will often, at least in 60, 70% of cases, go on to develop prediabetes. Prediabetes is really diabetes for all intents and purposes. It's just, we tend to make a somewhat arbitrary distinction between diabetes and prediabetes, and really that's because the level of blood sugars in a prediabetic are not necessarily high enough to cause eye injury, for instance, or neuropathy. Though, that even that theory has been broken down. So that's kind of an arbitrary difference. By the time you get prediabetes, it's sort of like telling someone they have stage 1 breast cancer, but they don't really have breast cancer, and yet we all know they do, right? So,
Right.
yeah. So it's prediabetes is definitely a product of insulin resistance, but it's not necessarily insulin resistance itself.
Can you test for insulin resistance, and is it tested differently than like the glucose test that we use
Yeah,
for
yeah,
diabetes?
definitely. Yeah, I mean, in my former career as a clinical scientist, I do more diagnostic science right now, but I would routinely test patients, and the way we did it is we would give glucose, and then not only would we follow their glucose levels after we gave a patient a glucose drink, we'd not only follow their glucose levels over time, we would follow their insulin levels over time. And between the glucose response and the insulin response, there's a mathematical relationship you can calculate, which pretty much tells you just how insulin resistant someone is. It turns out people who are more insulin resistant, and this probably would make sense to you if you think about it, have much higher insulin levels after you give them glucose, because their body needs to crank out even more insulin than the average person in order to offset their insulin resistance. So that's why it's a really good marker for insulin resistance.
Interesting. So a question just came in. Curious to your thoughts on the correlation between COVID death rates and low vitamin D levels. Would it be beneficial for employers to offer vitamin D levels which are low for a majority of Americans? Offer vitamin D level testing. Is that an option?
Yeah. Oh, yeah. That's actually an inexpensive test, and it is absolutely true that there's been some data that suggests that may be a risk factor for more rapid progression of the disease. Like with so many emerging diseases, we have absolutely no idea why that would be the case. And it's kind of interesting that someone even did that test, but they were probably looking at all possible factors in blood retrospectively and came up with that. To know for sure, you would have to, the type of thing you'd have to do, and we don't really have time to do that in this pandemic, but the type of study you'd have to do is a prospective study where, people are given vitamin D supplementation versus people not given supplementation, and you follow them to see how they do over time. We just don't have time in a pandemic to do that. So I see no harm whatsoever in checking vitamin D levels and supplementing vitamin D. Vitamin D is harmless unless you have some ridiculously high dose that causes high calcium, but you gotta really work to get it up that high.
So employers supplementing their employees with vitamin D is a feasible way for employers to prevent additional costs, maybe?
Yeah, definitely. I mean, you'd have to really do a lot more science to prove that. But, to me, all of these things, these interventions that we're doing on the fly without the right type of clinical trials have to be looked at from a risk benefit standpoint. And if vitamin D gives potential benefit and has almost no risk, why not?
Yeah, interesting. So let's go back to the whole diabetes. If it's the type 2 diabetics that are struggling the most, and that's a preventable disease, it really underscores the need to boost your immune system as well as prevent type 2 diabetes by exercising and better nutrition and taking care of your body. As a
Yeah.
physician, give us your perspective on that.
Well, obviously people can't go back in time to fix, their type 2 diabetes at this point in the middle of the pandemic. But I think it does illustrate that we are, as an obese population that has rising rates of type 2 diabetes, we are probably setting ourselves up for greater vulnerability across the population to all sorts of infections. And, in addition to the stuff I was telling you about the vascular propensities to vascular disease of type 2 diabetics, they also have some impaired immunity. So we know that type 2 diabetics don't have good wound healing. If you measure the function of what are called neutrophils, a type of white blood cell that's like sort of like the firemen that arrive immediately when there's an infection, those are pretty impaired in type 2 diabetics as well. So I do think that this amount of type 2 diabetes in a employee population is really a setup for cost, especially if you're a self-insured employer. These are going to be your expensive patients who are coming in with more frequent problems.
Gotcha. Another question just came in. What are your thoughts on the work of Dr. Jason Funk, an endocrinologist who treats his diabetic patients with fasting interventions?
Yeah, it's funny. I had a patient who brought that physician up to me, and I looked at some of his work. I think so intermittent fasting, it works. It works because, among other things, it takes advantage of what's called metabolic flexibility. And let me give you an example. So normally a healthy person, when they are able to eat, their body converts to burning carbohydrates. When they're not eating, which is typically when you're sleeping, your body has a nice smooth switch to burning fat. And fat can accumulate not only in your adipose tissue, that is your fat, literally, but also in other organs like liver and muscle. And that's where insulin resistance partly comes from. And so intermittent fasting addresses that by forcing people to utilize more fat out of their body and utilize less carbohydrates. And that's really how it has benefit for diabetics. Whether it gets everyone off medicine or not, I think that's a little unlikely. But I will tell you, I've seen some very successful people who've improved their overall diabetes outlook with intermittent fasting.
What does that look like? What does intermittent fasting, just from a practical standpoint, look like? How often? For how long?
Yeah, I mean, it can be eating a small meal in the morning and not eating again until later in the day, like 5 or 6 p.m. It's kind of interesting. A lot of us do that anyway, just because we get so busy during the day. But honestly, I've got patients who actually do eat throughout the day, and for them, that's a significant fast. It can also be a whole day fast. There's a lot of different protocols for intermittent fasting.
Interesting. So I love your thoughts, and if this is an area you don't want to go into, just say so. But retainer-based care, where instead of on a fee-based, it's more retainer-based. Tell me about your interest in, especially as a specialist in endocrinology, the idea of possibly doing retainer-based care. It's become fairly common in primary care, but not heard about it a lot in specialists. But I think in a diabetic population, retainer-based care could have some real value.
Yeah, I mean, your average diabetic patient has to be seen 4 to 6 times per year, but they also have like ongoing problems that have to be dealt with on a regular basis. Right now, access is a major problem for diabetic patients. A lot of primary care practices are already up to their ears with patients, and many of those patients are coming in with sort of acute problems like, bad head colds, or, they bumped their elbow, whatever. Whereas the diabetic kind of has to come in for the same thing over and over. And the other thing that's affecting diabetics, besides their need for regular care and sort of care in between their visits, is that a lot of patients simply can't afford their medicines, or they are in high deductible insurance plans, or they're uninsured, and they have no access to care at a reasonable cost. So one of the things we've been pioneering is a clinic-based model that's almost a membership. Well, it really is a membership, where for a relatively nominal fee of about $99 a month, diabetic patients can get 24/7 care, as many visits as they want, as often as they want. They can get telemedicine, they can get phone calls, they can get text. And, it sounds like, gosh, how do you do that for $99 a month? Well, it turns out most diabetics like having access and are willing to pay for it at a reasonable cost. They don't want to have to pay out of pocket $400 for a 45-minute visit. And so the value for them really adds up quickly. They like the idea of just sort of being able to get hold of someone, the insurance, if you will, of having be able to get hold of someone on need, on call 24/7. And what's interesting is most of them don't overuse the resources. So you know it actually ends up being very doable for practices that take this approach.
Very interesting. I have never heard of retainer-based care for a specialty area, but it makes so much sense. And it sounds like you've actually got a number of patients that are trying it out. Are you aware of other endocrinologists that have done this?
Nationally, I did a search and I've only been able to find one, and it's actually that model is a little bit more like what's called concierge care. And what that is they normally take insurance as opposed to sort of cash and membership-based payment. And what they do, though, is that if you want that extra special touch of care, you pay extra on top of what your insurance is paying. That's kind of more of a concierge model. The problem with that is it's not very democratic, and it really doesn't encourage people who are struggling financially to sort of utilize the services. They tend to those concierge practices tend to sort of self-select for wealthier patients.
Right.
The other thing about this sort of the sort of membership-based care, for companies, it makes a lot of sense to actually provide that as a service to patients. If you think about it, as I've said before, your diabetic patients are going to be the cost consumers for your health plan, and if you can prevent them from ending up in the hospital, in the ER, any sort of excess risk that they may bring to your organization, if that can be mitigated, the savings is obvious.
Well, and the alignment is, for me, a critical thing. In the case of a retainer-based program, everyone's working to keep the patient as healthy as possible. There's no misalignment of incentives for like fee-based billing.
Oh yeah, absolutely. In fact, it actually turns it on its head, right? I mean, we want to get people as satisfied as possible and out the door as satisfied as possible, so that they don't have to come in and keep utilizing services, which it's a win-win for everybody.
Well, and for the employer, that's why I say I love what you said about
for the employer, for sure. Yeah.
So one of the questions that just came in is, what's your opinion on wearing masks? Is there evidence that they actually work?
Yeah, there is. That the CDC has been evolving its thinking on this quite a bit. They probably don't protect you that much, but they definitely protect your other people around you. The theory, think about this: if they're only even if they're only say 70% effective in preventing you from infecting someone, and let's say the person wearing the mask, it's only about 30% effective in preventing them from getting it, which is probably actually fairly accurate numbers. You've still reduced the risk from almost 100%, because honestly, it's that infectious. It's as bad as measles. You've reduced the risk of infection from almost 100% down to about 0.21, 20% if you do the math. So from a population standpoint, there's absolutely no doubt that masks are critical in keeping it from running rampant through populations. And they will protect you a little bit, especially if the person you're interacting with is also wearing a mask.
Well, and to that point, I know we're almost running out of time, but to that point, I think there seems to be less and less, at least I'm experiencing, interest in wearing masks. It's like some organizations are requiring it. You can't come in unless you've got a mask, but a lot of organizations are not, and it seems as though fewer and fewer people are wearing masks.
Yeah, it's really interesting. I mean, in Utah, we sort of had, we have this, yellow, orange, red status sort of thing going on in terms of how we're supposed to be doing social distancing, and whether companies are open or closed and what types of companies. And as we've moved from red to being more open in the orange zone, literally the day they announced that, I went out and I saw like almost no one with masks on. Suddenly it's like, no, I wanted to take people and shake them and say, no, the virus is still here. Nothing has really changed.
Exactly.
It's like, it's still here. It's still going to infect people, and you still have to take precautions.
So another question just came in. Since prediabetes and diabetes risk is heavily related to day-to-day behaviors, poor sleep, stress, diet, exercise, does your office encourage or provide behavior-based health coaching to manage and or reverse their conditions?
Oh yeah, you bet. I mean, that's actually the main pillar of our treatment for patients. I mean, if we're not providing that, we can throw all the medicines in the world at people and they won't get a whole lot of overall wellness. Medicines can kind of, put a finger in the dike, so to speak, so that there's not a flood. But in terms of, patching and repairing it permanently, if you can get people, to do positive lifestyle modification, that's what's really impacting their long-term health and longevity and everything else, quality of life. And so we've got diabetes educators in our program, as well as the exercise physiologists on call who can provide services to basically help patients individualize their lifestyle change plans.
Nice. Awesome. I want to mention, because you brought it up a little bit earlier, I'm not sure if you're aware of, but there's a company called RX Help Centers that provides relief for people who have expensive ongoing medications. And basically, anyone that's spending more than $50 a month on medications out of their pocket should seriously look into RX Help Centers as a form of keeping their cost at least to $50 a month.
Wow, how does that work?
They actually go to the manufacturer. A lot of these people have insurance. They go to the manufacturer, they ask for relief, and as you know, manufacturers only give relief to those who don't have insurance and are economically depressed. Well, they get that denial letter from the manufacturer of the drug, and they're able to take that denial letter to many philanthropic groups, as well as associations, who are more than happy to fund and support those who have to have ongoing medications but can't afford them. And so they link those funding sources to people that are struggling that have more than a $50 a month cost on medications.
Wow, I mean, that's an amazing, I didn't know about it, and it's an amazing program, and I'm certainly going to help my patients take advantage of that.
There's another organization, I think it's called Prescription 360. It does something similar. It's more for those who are significantly economically depressed. So and I think it reduces their cost to $25 a month. But you have to meet a certain economic threshold to get that assistance, where RX Help Centers, almost anybody can get relief. Their economic position is not so tied to it, as I understand. So,
Darrell, are there any limitations in terms of what types of patients? Like some of these programs, for whatever reason, they won't provide services to Medicare patients. Do you know if there's any limitations like that?
I think the Prescription 360 is specifically for a lot of the people that are on Medicaid. The RX Help Centers, I don't think has any restrictions. And it not only helps the patient, but it's a tremendous support to the employer too. Both the employer and the patient get relief by accessing this RX Help Centers. So it's rxhelpcenters.com if you want to go to it.
Oh, that's excellent. I mean, because what you'll find is even if patients have insurance, in some cases they can't afford their meds, and like especially with diabetics, they'll ration their insulin, which means their blood sugars are going to be disastrous, which means they're going to end up with complications that the employer is going to probably have to absorb at some point.
Well, and with the popularity of these high deductible plans, that's become more and more a concern, because until you've spent the first $3,000 or $4,000 and sometimes $6,000 or $8,000, insurance doesn't kick in. You got to, if it's not a prevention like a colonoscopy or a well visit, it's coming out of your pocket.
Yeah, exactly.
So Dr. Grahm, we're about out of time, but I'd love to give you a few minutes to just share anything that we didn't get a chance to cover. You've answered some amazing questions. Thank you for those that are participating with questions. Just any last minute thoughts that you have that you can share.
Yeah, there's one thing we didn't cover that much, and it's the role of antibody testing. And I know this comes up for a lot of employers. So the idea is, can you test people for antibodies? And if they have antibodies, can you kind of certify that they're ready to come back to the workforce safely? And I would just caution everyone about that. The CDC just came out with a similar caution that probably most antibody testing on average is no more than 50% accurate, which means it's the flip of a coin whether you're actually getting an accurate result or not. And so this is going to be how we deal with people who are past the state of infection, who may have antibodies. How we craft policy around that and how we re-enter those patients into the workforce is really going to be tricky. So that's just one parting, not to leave you with a big question mark, but that is one parting thing I wanted to add, that I just want to make sure we covered that.
Will you, in closing, just share, I know, I think the work you're doing in developing some solutions for employers is fantastic. Will you just maybe share how people can get a hold of you or access your organization if they're interested in pursuing some of the services that you're developing?
Oh yeah, absolutely. You can call me directly at 801-214-5399. That's 801-214-5399. Give me a little bit of time to get back to you. Feel free to leave a voicemail. In addition, if you want to email me, that's totally fine. It's tim.graham, like graham cracker, Graham, at Progenitor Inc. And Progenitor is spelled PROGENITORINC.com. And that is probably the easiest way to get a hold of me, and feel free to call me.
Fantastic. Well, thank you very much. This has been very enlightening. I've enjoyed this conversation immensely.
Yeah, me too. Great.
So in conclusion, I'd just like to mention that our guest panelists for this next Monday, June 1st, will be Stephanie Iliff. She's the founder and CEO of a company called Powerhouse, self-love coach, podcast host, motivational speaker. Steph will be sharing some ideas and thoughts about learning how to better understand and address our feelings. We'll be sending out a post-huddle survey. Please give us your thoughts, your feedback. We'd appreciate that. If you've got any ideas for topics or themes for upcoming huddles, please share those. And if you've got someone you'd like to recommend for an upcoming guest panelist, please share that as well. You can contact us through the Contact Us form on goingonoffense.com. Again, we want to thank our participants and specifically Dr. Grahm for his participation today. Thank you.
My pleasure.
And we want to thank the organizations that have gotten behind this. There's a number of organizations, if you'll go to the website, that have shared resources, ideas, suggestions, discounted services, free services. Employers and individuals can take advantage of those resources that are offered. And again, we'll be recording. We are recording the huddle. We'll be posting this later today. And we're going to sign off now, say goodbye, and hope everyone will join us for a future huddle. Again, we hold these every Monday, Wednesday, and Friday at the same time. Have a great day.
Bye.